Well, good evening and welcome to our Family Life Enrichment series. I'm so excited to welcome you with us this evening, and I want to invite you back to be with us for the rest of our series. This is the first of a number of sessions that will be taking place between tonight and the Wednesday right before Father's Day. So we dedicate this time between Mother's Day and Father's Day every year for our Family Life Enrichment series. This series was planned by the Churches of God at the Garden, Silver Sands, and Minor Quarter. And we thought it would be great for us to get together and to look at various aspects of family life. We are in for a treat tonight, and I just hope that if you haven't invited a lot of people to come and be with us this evening, that you get on your phones right now, or you start texting, you start calling and saying, listen, you are about to miss a great session. So please join us. Send the link to as many people as you can. I know that many of you have already done that, but we are going to be looking at the pause factor. What an interesting way to start our Family Life Enrichment series. And so we have a very, very special guest this evening, Dr. Renée S.T. Boyce, who is with us this evening. She is going to get us started with our Family Life Enrichment series. So exciting to welcome Dr. Renée to be with us this evening. Dr. Boyce is a graduate of the University of the West Indies class of 2004, where she received her MB, Bachelor of Science degree, and a postgraduate diploma in family medicine 12 years later. She worked in the Department of Hematology before transferring to the Winston Scott Polyclinic. After working in the public system for over a decade, Dr. Boyce transitioned to private practice, where she currently manages her general medical practice, North Point Medical Services. She is also a part-time tutor at the University of the West Indies Capel campus in the Department of Pediatrics. Over the years, Dr. Boyce discovered a passion for public speaking and teaching and has facilitated numerous lectures for churches and other social groups on various aspects of health. She has been a repeat guest on Morning Barbados television program and a weekly columnist in the Barbados Today newspaper. For 5 years, she was the host of the Better Health radio show on VOB 92.9 FM. She is an avid musician, capable of playing 4 instruments, and has been a keyboardist at her local church for nearly 30 years. She has been married for 19 years and is the mother of 2 children, ages 15 and 11. Dr. Boyce believes in striving for excellence and has completed her master's in healthcare management with distinction and is a certified corporate wellness specialist. Her purpose in life is to help others become the best versions of themselves by optimizing their health using the medium of education. I know that she's not going to hear you applauding, but help me welcome Dr. Renée Boyce to lead off our discussions in our Family Life Enrichment series. Dr. Renée, it is so great to welcome you to our session this evening and to have you lead us.
Good evening, and thank you so very much, Pastor Lennox. It really is my pleasure to be here. I'm just making sure that I can be heard loudly and clearly. It's crystal clear.
You can be heard and you can be seen loudly and clearly. And we are excitedly waiting for your presentation. I can't believe, well, I can believe because I know what your musical journey has been like, but the thought that it is already 30 years, you look like 30 years yourself.
Oh dear.
So yeah, but welcome, and we look forward to your presentation this evening. God bless you as you present. I know that our people are really going to be better for your presentation this evening. So I'll just leave you alone and just let you go ahead and present.
Thank you so very much again. It really is my pleasure to be here presenting. It is always pressured to be the first one to do anything. And whilst I'm honored to be the first one in the series, I have to make sure that I set the bar high and display the excellence that Church of God really has become to be known for. So let's go to our presentation. I entitled this evening's presentation, Do We Really Need to Pause? And we're going to be discussing menopause and andropause. So the way we're going to do it, I'm going to deal with the basics, because these topics in and of themselves need an entire session to really flesh out all the different issues. So my purpose here tonight is to educate you on the basics of these two topics. And let me say, I have a dog who knows when it is time for a presentation to happen. He was completely calm until I started speaking. So if you hear him in the background, that's just him joining in our presentation. So first, we're going to define some terms. To help us understand what we really are talking about, we need some basic definitions. And menopause and andropause, they're both based on hormones. So we need to understand, I believe, how hormones work and their function, and to be able to identify the symptoms of andropause and menopause. And it makes no sense understanding symptoms or being able to recognize symptoms and not knowing how to deal with these particular symptoms. And then we'll go on to discuss a few complications of both andropause and menopause and take a look at what society thinks and says. And of course, your questions and your thoughts and opinions are important to us. So at the end, we will have some questions. So you've heard these terms being bandied around: testosterone, estrogen, progesterone. You know, the guys talk about all the testosterone that they have. And when some persons are talking about women, oh, it's the hormones that have them crying 1 minute and sad another minute. So when I was back in medical school, 20 years ago, the definition that we used was compounds that are produced in one part of the body and they have their effect somewhere else. Those are hormones. That's just a basic definition. An example I could use would be the thyroid hormones. The thyroid gland sits here in the neck, but the effects of the thyroid hormone, those effects are felt all over the body. They have an effect on our metabolism in the gut. They have an effect on our weight. They have an effect on the heart rate. So they're produced one place, but they have their effect elsewhere. Back in 2019, the dictionary said the hormone is a biological compound. It's used by multicellular organisms to organize and coordinate and control the functions of their cells and tissues. So these are lots of words, which means that hormones, they're made in the body. We are multicellular organisms as human beings, and dogs, like my dog outside. And for the body to function optimally, there needs to be coordination and organization and control of the cells and tissues. You can think about cancer, for example. If you have disorder of growth and death of cells, this is the underlying basis for some cancer. So we do need hormones to regulate function in the body. So let's look at a few more medical terms. Menarche, that's the first menstrual period. Menstruation, monthlies, periods, time of the month, evil time, and flow. These are all names that are given to periods, and they're commonly called periods. It's that process in a woman where blood and other materials are discharged from the uterus at intervals every month, and it starts from puberty until menopause. And unless there is a significant medical condition or during pregnancy, that's the way it goes every month, like clockwork, unless something else is wrong underlying. So menopause, and you notice there are 3 M's: menarche, menstruation, and menopause. So menopause is the cessation of menstruation. That's it, shut down. And it can occur anywhere from the 40s and 50s. And in the US, the average is about 51. The important thing that we're going to get into a little bit later on is that menopause is actually a retrospective diagnosis. So the technical definition of menopause can only be made in retrospect, and we'll explain it a little later as we go on. So as you can tell, we're starting with the ladies. Now, The purpose of this diagram is to demonstrate two things. If you cast your eyes to the middle row here, we can see that the different hormones, FSH, estrogen, luteinizing hormone, progesterone, they are at varying concentrations during the monthly cycle. And this is what allows periods to happen. So you don't get a period if you're ill, if you're on some form of external hormone, or if you're pregnant, or if you've gone through menopause. So the purpose of this is just to demonstrate that hormones play a significant role in the menstrual cycle in females. So the ovaries, they're pelvic organs, so we can't touch our ovaries, and they prepare eggs for ovulation. That's their primary function. And they also make the hormones estrogen and progesterone, and that we saw in the previous slide, that are at varying concentrations during the menstrual cycle, which either allow for implantation of a fertilized ovum or a period to happen if no fetus is implanted. All right.
Doc,
yes.
Your screen is not sharing.
Oh.
Yes. So. All
right. What's the last one you saw?
We didn't see any slides.
Really?
Yes.
And I'm here.
So
okay. Let me.
So only when you said like I realized that you thought I thought it was me, but then I realized that a couple other people weren't seeing it. We understand. That's okay. Yes.
All right, here we go again.
But for the visual learners out there, I'm sure that they'll appreciate seeing your slides as well.
And I work very hard on them. So yes, we will see them.
Well,
all right, let's try again.
That's all right.
Let's try again. So just give me a second. Let me pull them back up. So the slides had actually shown we started with the definitions, and then we had gone on to what we were planning on doing. Let's see if this one works.
There we go.
Okay, wonderful. And purple is my favorite color. So awesome. I would have been thoroughly disappointed. All right, let me just put it to slide screen and we'll go again. All right, we're good there?
We are good.
All right. So this was our outline, what we're going to go through for this session, understanding the basic terms all the way up to questions and answers at the end. And we discussed, without you seeing, what hormones were. And we went through some basic medical terms. Menarche, the first period, menstruation, and we call it by all the different names, Aunt Flo, the evil time, that time of the month, and menopause. And the important point I want you to keep in mind is that menopause is a retrospective diagnosis. And here, this is the slide I was talking about, where if we cast our eyes on the second row here, these are the various hormones that are involved in the menstrual cycle. Follicle stimulating hormone, estrogen, luteinizing hormone, progesterone. And the varying concentrations of these hormones allow for a period to happen if there is no fertilization of the egg and implantation doesn't occur. And this happens from the time that the female hits puberty all the way up to menopause. And it stops only if you are on external hormones, there's an underlying medical illness, or you're pregnant. So the purpose of the ovaries is to prepare eggs for ovulation, and the hormones estrogen and progesterone that we discussed just now. And it's important for conception or menstruation, as we said just now. So these ovaries, once the function starts to decline, the end result is menopause. So these are some symptoms of menopause. Irregular periods. So persons who were previously regular, that they could set their watches by their period, all of a sudden realize that periods are either increasing in terms of frequency, or the length of the period is increasing. So no longer is it that previous 5 to 7 days. Now you're having a period for 10 days, 14 days. And when you think you're over it, there's another one right there. Or you have a period we're in May, and then June, nothing, July, and you're thinking, oh, yeah, home free. And then August, hi, I'm back. And then we have vaginal dryness, one of the complaints that some of the women who are going through menopause experience. And this is because of the decline of the hormone estrogen. So when we get to treatments, you'll understand the purpose of treatments. Hot flashes. Everybody understands what a hot flash is. Personal summers. Previously, they were called, or in some quarters, they're called hot flushes because you can actually, in fairer persons, see a flush of color going up the face and they turn red and then they start to sweat profusely. And some women with the hot flashes, they feel ill. Other women, they're just annoyed because, you know, it's happening. And sometimes you can feel unwell after, your heart can be racing. So various symptoms go on with these hot flashes. And then on the other end, you can get chills, night sweats, insomnia, mood changes. And I'm sure that there are some men who are hitting the table saying, yes, yes, yes. Another symptom, and if you look at the ads that you see on Instagram and on YouTube and so on, you would see that they're talking about that postmenopausal weight gain. And that is something that does happen. We can have a conversation about that, about are you concerned to gain weight in menopause? Are you going to be fat once you go through menopause? That's something that we can discuss. So think about it. And another thing would be thinning hair and dry skin, changes in libido, memory challenges, loss of breast fullness. So another condition that leads to loss of breast fullness would be having had children and breastfed. You know, before you had those children, your breasts were perky and up in the air, and the children suck the life out of them, and then they're like two socks hanging, right? So the same thing happens in menopause. And I put those dots there because menopause for one female is not the same as menopause for another female. There are some fortunate females who can go through menopause and not even recognize that they're going through menopause. And then there are others who almost lose their minds. There are some who can't function, the memory impairment, the hot flashes, the other symptoms like depression and so on. They're just so terrible. So it is a unique experience, and I feel the experience is best managed by understanding. And the Bible can't lie. My people perish for lack of knowledge. If you don't know, then your experience of menopause is not the best that it could be. And we'll discuss that after. So the question is, how do I know I have reached menopause? Recently, I was talking to one of my patients, and she was explaining a few symptoms. And I said, well, you know, it sounds as though you could be, you know, getting ready to go through menopause or starting menopause. And she told me, no, she's fighting a cold. So the question is, how do I know I have reached menopause? Well, here are a few tips. Are you in the age range? So if you are 28 and you're having problems with your period, they're irregular, menopause is not going to be the first thing that I would think about as your primary diagnosis. On the other hand, if you are 54 years old and you realize that your periods are heavier than before and you're having more than one period in a month and then some months no period, then I'm thinking, yes, possibly this could be menopause. Do you have suggestive symptoms? So we went through that long list of symptoms there just now. Dry hair, weight gain, insomnia, vaginal dryness, sagging breasts. So do you have suggestive symptoms? Have 12 months passed with no period? So remember just now I had mentioned that menopause is a retrospective diagnosis. So you can only say that you have gone through menopause when 12 calendar months have passed and you've had no period. So we're in May. Let's say let's use earlier up in the year. So there was a period in January, February, nothing in March, April, but you had a period in May. you wouldn't be classified as having gone through menopause. However, if since January last year, you had no period all the way to December, then you would have gone through menopause. The important thing is to make sure that an underlying medical disorder has been ruled out. And I say that with a pinch of salt, because most people would understand that they're going through menopause. You know, you reach a certain age and you expect that this is going to happen at this point in time. But many of the symptoms of menopause are similar to symptoms for other medical diagnoses. For example, thinning hair and weight gain. You can see that in hypothyroidism, which is underfunctioning of the thyroid gland. Insomnia, can get that in hyperthyroidism. So if the diagnosis of menopause is not clear, then you have to make sure that we're not dealing with another underlying hormonal or other medical diagnosis. So if you've answered those questions in the affirmative, then more than likely you've gone through menopause. So what are some of the complications of menopause? Now, if you think about it, most of the females who have heart attacks are in the postmenopausal age. It's unlikely to see a 22-year-old female with a heart attack unless there is some underlying medical condition. She had a congenital heart problem, she was born with a heart problem, or there's some other genetic problem that has led her to be more likely to get a heart attack at such a young age. But generally speaking, it's usually the postmenopausal women who get the heart attacks and strokes. The hormones, estrogen and progesterone and so on, they're also playing a role in the development of bone. And therefore, when these hormones are decreased, we get a decrease in the density of bone, a decrease in how bone is being made, how rapidly those bone building cells are being built up. And therefore, these women are more likely, to get a fracture if they fall. So the old people were right. You don't wait till you get old to fall. Again, urinary incontinence, so bladder control is also one of the features of the hormonal control. So you would find that women tend to, at some points in time, wear the thicker liners to absorb the drops of urine that might occur when they cough or sneeze or laugh a lot. And studies are saying that there's a higher risk of Alzheimer's with menopause. And this is one of those things in medicine, because you see menopause in older women and you also see Alzheimer's in older women. So is it the menopause that's causing or related to the Alzheimer's, or is it the feature of aging that's related to Alzheimer's? So one of those caveats in medicine. And of course, the reduced muscle power. And some of my older patients complain that once they start getting old, that they start seeing the sagging there, they lose the muscle bulk and the muscles are not as powerful. So these are the symptoms that we've gone through. We see that there are complications that can occur as a result of having gone through menopause. So the important thing is that there is treatment available for menopause. Since menopause is as a result of a deficiency of hormones, then it stands to reason by replacing these hormones, the symptoms of menopause should be alleviated. So you're not going to start the ovaries creating hormones again, but because you have introduced hormones externally into the body, then you should get an alleviation of those symptoms. Vaginal dryness was one of the complaints that you would have seen on the slides there. So some of the ladies who complain about vaginal dryness, they might have tried some of the over-the-counter lubricants and found that those did not work. And the topical estrogen creams have proven to improve the dryness of the vagina. Antidepressants, because remember I mentioned before that depression is one of those things that can happen as a result of going through menopause, the change in hormones. And sometimes, having gone through menopause, I'm getting older, and then all the other things that come along with getting older. Some women do become depressed and might require treatment with antidepressants. One of the things that you can also do is supplement vitamin D, which is important for your bone health. And in severe cases where there is documented osteopenia, which is a slight lessening of the bone density, all the way up to osteoporosis, which is the real deficit in that bone density. Now the bone is disappearing. They can be placed on medications to reduce the level of osteoporosis, or in some cases, you can actually prevent the osteoporosis. And some of the anti-seizure medications have been shown to relieve the symptoms of the hot flashes. So these are the Western type medicines. And I find that women are very reluctant when it comes to hormone replacement therapy. And a lot of it has to do with not knowing, not understanding. So there are complications to every single treatment that is given. Paracetamol, deemed to be one of the safest drugs, if taken in excess, can cause trouble with the liver. And the thyme that you have in your backyard, if you use excess of that, that can cause problems. If you go out in your garden and you pick something and you boil that and you drink it, you're not certain of all of the components which are in that particular leaf. So both alternative medicine and the traditional medicine, they have their complications. So there was talk about associations with breast cancer, blood clots, and strokes. So scientists are saying that once you are less than age 60, that the risk for these complications is low. My take on it is have a conversation with a trusted physician or other healthcare provider. You can talk with your gynecologist, you can talk with your general practitioner, but make sure that you don't make a decision solely based on fear. Do your research. And we're going to talk about research a little later on. And another thing that I want to caution about is that you don't make your decisions about your health based on another person's experience. Each of us is individual. And I will give you a classic example. The drug that we know here in Barbados, commonly Histol, it's an antihistamine. I can't remember the chemical name for it now. It's an antihistamine. Chlorpheniramine? Yes, chlorpheniramine. Hope I'm right. Nevertheless, I have a friend who can take Histol and run laps around the garrison. If I take Histol, same dose, if I take Histol, I have to lie down. I must lie down. I cannot function. I cannot sit up straight. And it's the type of sleep that leaves the deep grooves in my face. So each of us is individual. So menopause for one person is not menopause for another. The experience of the menopausal symptoms in one person, they're not the same for another person. And therefore, stands to reason again that using or not using hormone replacement therapy is an individualized thing. And you need to have that conversation with your general practitioner, your nurse practitioner, your gynecologist, your pharmacist. These are the persons that you need to have this conversation with. Now, I put this here post-menopausal bleeding. Remember, we spoke about menopause being 12 months in retrospect with no bleeding. If you've had menopause and you realize that you are having vaginal bleeding, you need to see your gynecologist quick, fast, and in a hurry to make sure that there's not an abnormal growth of the lining of the uterus, that there are not polyps or any other sinister things going on in the reproductive system. So you don't think that, oh, my period has started back. You need to think something might be going on that's not quite right. Let me go and get it checked out. So this is one of the take-home points here. Postmenopausal bleeding is an emergency. You should see your doctor as soon as possible. So lifestyle changes. I was doing some research for different presentations that I have to do. And at one point in time, I will honestly tell you that I became annoyed because every single management aspect said lifestyle changes, lifestyle changes, lifestyle changes, but it makes sense. It makes sense. So I was talking to my sister earlier on, and I was telling her about the menopause seminar. She's younger than I am. She said, yes, I'm 41. I'm going through menopause, you know, the hot flashes, you know. All you have to do is buy a fan for $25 and it will pass. And she's right. You try, and it makes sense. If you're hot, you keep cool. So you drink cool drinks. You can chew on ice or sit what do you do with ice again? Because the dentists say you are not to chew ice. You are not to chew ice. So you can suck on ice. You can suck on the ice chips. What you do is layer. Let's say that you work in an office where you wear a uniform, you wear a jacket, and so on. So you would wear something under that you can slip off the jacket in case you get hot flashes and so on. And in the other countries, you wear different things. So you wear a vest underneath, and then you can wear maybe a camisole and then a shirt over there so that you can take off the layers if you're getting hot. When you have to go to church, you find the seat that is closest to the fan. You're going to a meeting, look for the AC vent, and you try to stay as cool as possible. Exercise. You know, when the Lord said that we should work, he understood what he was talking about. Stay socially active. Remember, I said that depression was one of the things that can happen. So you stay socially active, and it's easier to manage symptoms when you have a social support system. You could feel as sick as a dog, but when your friends are around you, and you can think about it, you feel better when your friends are around. And it's in the Bible again. Laughter is the best medicine, and a cheerful heart, and those things. And you talk about when you're sad, the bones are dry. So stay socially active. Reduce alcohol consumption. So if you are prone to drinking in excess, you know, try reducing the alcohol consumption. Especially, remember, alcohol makes you feel warm. You get this warm flush. So try not to take too much alcohol. Smoking is bad for your health. This is what the Minister of Health advises us. So try not to smoke. And you use Kegel exercises. Remember, one of the symptoms was bladder weakness or instability. So Kegel exercises strengthen the floor of the pelvic wall, and that should help with the bladder leakages. You can try the over-the-counter lubricants and moisturizers for the vaginal dryness, and you try to relax. Nothing ever feels better if you're under stress and tense. Stress and tension are not good things to have for any illness or condition. And in order to relax, again, you see exercises there. You do your stretches, you do your massages, and you do meditation. Now, in the church, people get very wary about doing meditation. The issue is not meditation. The issue is on what are you meditating? So if you are sitting and you are meditating on, by his stripes I am healed, the prayer of faith will heal the sick, well, then these are good things to meditate on. I think it's in Philippians, whatever things are true, just of good report, think on these things, and this will help you to relax. Now, there was a study that followed 45,000 British women for about 4 years. And they found that the diets that were higher in refined carbohydrates, so this is pasta, white bread, and so on, brought on menopause a year and a half earlier. But those people who had more omega fatty acids and those persons who had whole grain bread and didn't eat the white bread and pasta and so on, they were able to stave off menopause, as it were, by about 3 years. And if you add to that lots of legumes, so those would be your lentils and black beans and your kidney beans and so on, you got another extra year without the menopause and menopausal symptoms. But you see, there is no specific menopause diet per se, but it is trying to eat the best that you can with the resources that you have, right? So no specific menopause diet, but those things, a diet in low in refined carbohydrates and high in omega fatty acids and legumes, tend to keep menopause off for a few more years. Just a little bit about perimenopause, because as I mentioned before, these topics in and of themselves, they require a whole discussion. So perimenopause, peri meaning about, occurs about 8 to 10 years before menopause, and it usually starts in the 40s. It's not the same thing as premature menopause, which is as a result of usually a problem with the pituitary gland, which is the master gland responsible for directing all the other glands to produce their hormones. And this premature ovarian failure is not the same thing as menopause, because menopause is a natural process of life, whereas premature ovarian syndrome or failure is a disease state. So perimenopause, like menopause, is this gradual decline in function. It's almost like a nebulous feeling. Something is not quite right. I can't put my finger on this particular thing. I don't feel like myself. You do get some menopausal symptoms, and I think most of the people in their 40s, they talk about brain fog. You can't remember things. I'm sure you heard that I forgot a couple things. And here we go. You forget a couple things, and then sometimes you're just not feeling well, you're feeling tired and so on. This is the time when you make sure that you go to your doctor and make sure that there isn't anything hiding underneath those symptoms that's as a result of another medical illness. The biggest problem that women get in the perimenopause era and in menopause as well is that nothing is wrong with you. This is what physicians say to patients, to the women, nothing is wrong with you. And when some of the women are complaining about menopausal symptoms, you know, they're brushed off. Oh no, you're too young, you can't be going through menopause. I am becoming very passionate about fighting for yourself. You know your body better than anybody else. And therefore, if you think that something is wrong and you are not getting the results that you want to get from a particular healthcare provider, find another healthcare provider. Somebody who's going to listen to your complaints, somebody who is going to try to understand things from your point of view, and along with you, come up with the best course of action, right? That's the important thing. All right, so these are just some of the symptoms of perimenopause. And these are some of the herbal supplements that persons have found relief for some of the symptoms: evening primrose and ginseng, black cohosh. And remember, you must check with your healthcare provider before taking any supplement of any kind to make sure that it is safe for you to use, all right? So this is the summary for menopause, the natural consequence of aging, and it's due to a decline in ovarian function and therefore a decline in those hormones that are produced by the ovary. It causes several symptoms, and some of them can be so disruptive. A medical diagnosis is not usually required, but in some cases, symptoms of menopause might be as a result of another underlying condition. So it might not be menopause. So it might be good to have that conversation with your general practitioner or your gynecologist. You can have medical complications like osteoporosis and increased risk for falls. You can be at increased risk for cardiovascular events such as heart attacks. There are prescription medications available as well as over-the-counter and alternative preparations. The important thing is, as with any illness, even although menopause is not an illness, you need a support system and an individualized care plan. Menopause is individualized, the experience is individualized. It impacts different persons in the family, it impacts persons at your workplace and so on. If you can't function at work, your menopausal symptoms are impacting on them, but the care plan has to be individualized. We're going to jump right over to the males, and we're going to look at menopause, andropause. So it comes from the Greek word andros, meaning man, and pausis, to stop. So literally it means man stop. And it was first coined in 1944. So andropause is really not a new thing. Now, these are different terms for andropause: male climacteric and male menopause. So technically speaking, andropause can't be called male menopause because menopause is the cessation of menstruation in a female. And since males do not menstruate, then they can't menopause. That's just my thinking. But you can tell me your thoughts after. But when I saw this name for a Adam, I thought it was very funny. They called it Adam, androgen decline in the aging male. So this is what's being bandied about. Is andropause a real thing? Or is it that the guys just wanted to have something equivalent to what the female has? So menopause in women, so let's have andropause for us men. I don't know. So what's andropause? According to the Oxford Dictionary, it's a collection of symptoms: fatigue, decreased libido, it must have decreased libido in it, experienced by some middle-aged or older men, and it's attributed to a gradual decline in testosterone levels. Another definition says a decrease in sexual satisfaction or a decline in feeling or in a feeling or of general well-being. So you just don't feel like yourself. And it's associated with low levels of testosterone in an older man. So again, like how you have primary ovarian syndrome failure in women, and that's not called menopause. If we have low levels of testosterone in a young male, that's not andropause. That's an underlying pathological disorder. Something is wrong that needs to be investigated. So the symptoms would be decreased libido, decreased morning erections, and erectile dysfunction, and evidence of low testosterone levels. And this is the normal range that we use in the lab for testosterone, for those of you who wanted to know the numbers. So this is what the andropaused male looks like. So if you know anybody that looks like our gentleman here, perhaps that person is going through andropause. So these symptoms: decreased muscle mass and strength, increased body fat, cognitive impairment. So we have problems going on in the head. We're not thinking as quickly as we used to before, mixing up things. Like the women, decreased bone density and osteoporosis, and less vigor. You know, you are just not virile, you're not manly, and men can become depressed as well. And another thing you can have would be the increase in the breast tissue. So these are some of the complications, and if you look at them, they look quite similar to the complications in females: heart disease and stroke, that weight gain, osteoporosis and risk for fractures, and depression, and an increased risk for suicide. Now, men tend to be more successful at suicide because their methods of suicide are usually more violent. So generally speaking, a man is not going to try to slit his wrist. He would try to hang himself or shoot himself or drink gramoxone, something that he is convinced is going to end his life. Right? So that's why males are usually more successful. But we have some diagnostic issues. Now, when it comes to menopause, it's usually, I want to say, precipitous decline. It occurs over 12 months, but you know that the hot flashes and the brain fog and so on and so forth, that this is menopause, and it's confined to a particular period of time. When we're talking about andropause, it's usually like a gentle stroll downhill. You know, these things are waning and they're weaning, and it's not so disruptive as it is in the females. So is it andropause, or is it just the normal aging process? So not all men who have low testosterone have decreased libido and erectile dysfunction. And not all men with erectile dysfunction and decreased libido will have low testosterone. So if this is part of the diagnostic criteria, then we see how it's muddled. We can't be 100% sure just because a particular male has low testosterone. doesn't mean that he's not going to be virile and the, the sheep in the ram in the community, right? And the thing about testosterone is that the values of testosterone, they vary throughout the day, as most hormones are. They vary by during the time of the day and so on, the time of the month. So the values vary based on when they're taken. So it causes a bit of a problem when we're trying to diagnose andropause. And like I was saying at the beginning, it's a gradual onset, which is similar to what we would expect in a slowing down as one gets older. Okay, so these are the symptoms, and the question the men want to know, you can fix it. Can it be fixed? Well, there are some treatments. There is only one approved oral preparation. There are gels, there are patches, there are pellets, there are injections, there are nasal sprays, and there's actually one you can actually put in your gum so that it, in the buccal cavity, that space there by your cheek, and it just dissolves. But like I said before, every treatment that you do, there are complications. So you have an increased production of red blood cells, and that runs the risk of increased clots. And you might get an increased amount of acne, enlarged breasts, problems sleeping, prostate enlargement, and limited sperm production. So some of the complications that can occur with treatment. So what we've done was to look, believe it or not, we're at the end because we want to have some discussion. This is just the basics, helping you to understand why these particular things happen in menopause and andropause. So we looked at those two syndromes. We looked at hormones and their functions. Testosterone is the male hormone, didn't mention it before. The male hormone, which is responsible for the development of your sexual secondary characteristics. So the deepening voice and broadening shoulders and that angular feature you see with the chiseled jaw and so on. Well, I mean, if you're fat and chubby, you're not going to see the chiseled jaw, but those more angular features that are seen with males, as well as lengthening of the penis, development of pubic hair. So those secondary sexual characteristics. And a little note here for men, some of the testosterone that you have is converted to estrogen. So you have female hormones as well. So when men get into their moods as well, just know that you have estrogen as well, and women have testosterone as well. We defined all of those relevant terms. We defined menarche and menopause and menstruation and what a hormone was and how they work. Importantly, we looked at the signs and symptoms of menopause and andropause, and we realized that there are some common symptoms. For example, that slowing down, the risk for depression. In women, there are other symptoms such as the hot flashes and thinning hair and weight gain and vaginal dryness. And with men, and both of them, they're at risk for osteoporosis and cardiovascular events. And we discussed the complications of these syndromes. Because of the lack of the hormones, you can get the various complications, like I mentioned, the increased risk for fractures, as well as the increased risk for things like strokes and heart attacks. We looked at the management. If hormones are missing, then it makes sense to replace the hormones that are missing. And the treatment of, like, for example, the hormone replacement therapy, that doesn't go on ad infinitum. It doesn't go on forever. It's only a particular length of time, which is determined by, for example, any underlying illnesses that the patient might have. What are you trying to achieve in terms of management of your symptoms? Because what one person is trying to achieve with respect to treatment is not the goal for another patient. Somebody else might be having terrible hot flashes as opposed to somebody else who might just have vaginal, I shouldn't say just, some person who is having vaginal dryness. So the goals of treatment, again, like the treatment plan, are individualized. And we looked at the complications of the treatment. For example, with the men, increased productions of red cells and acne and so on, and development of increased breast tissue. And with women, the risk for strokes and deep vein thromboses. These are clots in the deep veins in the legs. And in terms of management as well, apart from the prescribed drugs, there are alternative therapies which persons have used and found relief from the various symptoms. But the important thing in management is that it comes right back down to lifestyle. How do you eat? How active are you? What is your support system? Do you smoke? Do you drink excess amounts of alcohol? How do you manage your stress? Are you sleeping? Right? So this is my summary. So these are the final words. My final words to you. Make sure that you educate yourself from reputable sources. Reputable sources. And education, we live in society, and part of our education comes from those persons with whom we interact. Let's take, for example, mammograms. I had a patient who told me that she was not going to get a mammogram. And so I asked her, so why is it that you're not going to get a mammogram? Do you understand what a mammogram is? Do you understand the benefits? Yes, there are risks associated with the mammogram. So tell me why. Because somebody told her that mammograms are painful. So this is one of those comments where I would just put my pen down and give the head a little lean. So I said, so the reason you are not going to get a mammogram is that somebody who had theirs told you that it is painful. And then again, another, and it's not only persons you might meet on the street, I had another patient whose son told her that she should not get a mammogram because he didn't want her being exposed to radiation. Right? So you need to be educated for yourself, and you need to be educated from reputable sources. Online, do your research. And I think one of the things that we need as lay persons is to understand how to research. There are certain things that you need to understand, like the size of a sample. For example, if you have 10 people in a study, and this study is saying that you should take, let's see, green pigeon peas for menopause. These 10 people took green pigeon peas, and 8 out of the 10 found relief with menopause symptoms. And therefore, somebody is now coming on the market and saying, use this powder because persons are getting relief from menopause symptoms. 80% of people are getting relief from menopause symptoms with green pigeon peas. The study isn't valid. You only looked at 10 people, right? So these are some of the things that we need to understand when we go online and research. And a very good place is pamphlets from the healthcare providers, or you can ask your healthcare provider, you know, what websites should I look at? I can recommend webmd.com, Mayo Clinic. These are easy to read. For those of you who are visual learners, especially WebMD, they have some slideshows there that help with the learning. The CDC, Centers for Disease Control, and the World Health Organization. These are reputable sources, Cleveland Clinic and so on, where you can look for information. And you go to your doctor's appointments with this information and have a discussion. Make a note of your symptoms, because it's very frustrating for healthcare providers to ask, okay, so how long has this been going on? Well, I ain't too sure, you know. Okay, can you think of what brings it on? What brings it on? I don't know. Can you do anything to make it better? Well, I didn't really know, you know. It's just past, right? So you make a note of your symptoms, you write them down. Don't come with a scroll. Don't come with a scroll, but make a note of your symptoms and make sure that you make an appointment to see your healthcare provider and you make an informed decision. And this is the end of my presentation. So I hope that it is a bit of information to take in, but I hope that you were able to learn something, and let's see if there are any questions that you might have, anything that you want me to clear up.
Yes, hi, good night, doctor.
Hi, Pastor Burrowes.
Yes, I am back on. Right. Yeah, we do have some questions. Good night to everyone. The first question is from Yvette Waldron. How long does it take you to get menopause after a hysterectomy?
Okay, so there are different types of hysterectomy. Now remember, menopause is a natural process. So you can have a total hysterectomy or a subtotal hysterectomy. A total hysterectomy means that the uterus, the ovaries, fallopian tubes, everybody has been removed. A subtotal hysterectomy means that one or both ovaries have been left. And once the function of those ovaries has not been compromised by whatever reason the person had a hysterectomy for, then the process should be as normal in terms of menopause. So if that person was going to take, let's say, 3 years for menopause to start, it will be 3 years, because it's not determined by the uterus, but by the ovaries. So once the ovaries are there, they should function as they normally would have before.
Okay, thank you. We have also another question. Are there any available groups that can help assist men and women who are going through andropause and menopause in Barbados? Any groups that you know of?
I am not aware of a particular, like a menopause society and so on, but on the social media platforms, you will find groups of persons who you can type in menopause group, and you can find persons who are going through menopause or persons who are going through menopause. There might be groups in Barbados, but at this point in time, I'm not aware of a particular group. I know that there are healthcare providers who specialize in managing menopause, for example. But you can type in on the social media platforms, menopause support groups, and you would get information from there.
Okay, thank you so much. Another question. Some women, especially Caribbean women, decide after during menopause that their sex life has come to an end, and it put a strain on marriage. Any advice for especially Christian women?
Yes. No, I was a bit surprised. I'm very proud of myself, because I did have a slide on, and I called it the grinding halt of sexual intercourse in the pauses. And there are many reasons why either male or female would have problems with libido in the menopausal and andropausal years. For example, in women, vaginal dryness. Intercourse cannot be pleasurable with vaginal dryness. Cannot, right? It's painful, or it would be painful. Another thing with the decreased libido as a result of the decreased levels of estrogen. So therefore, it's going to take much more because we have to remember that having sexual intercourse is not only a physical thing, but there is a significant, especially for women, a significant emotional component. So if attention is not paid to the emotional needs of both males and females, but primarily females, that is going to lend to increased tension in the marriage. So you're already going with the decreased libido, vaginal dryness, and weight gain and loss of self-image that comes with menopause itself. And now your emotions are not being attended to, and therefore that will cause a significant problem within a marriage. And the menopausal years are a very good testing time to see what a marriage is made of, because very early on, I believe our young people should be taught that marriage is not only sex. That's something that they need to learn, so that when the menopausal years come and there is some decline, and we're not saying that this happens to every couple, because like I said, menopause and andropause, these are individualized periods in a person's life. But those persons who are blessed in that regard, that their sex lives don't take a dent during menopause and andropause, that's good for them. But the average person and most persons will go through a significant dip. And this goes to show the heart of the relationship as well, because if you realize that there's a problem, you need help. So help can come from a general practitioner. You can talk to your pharmacist, or counseling might help as well. So you have to be willing to do what is necessary for the marriage. On the other hand, there is something cultural that says once women reach a certain age that they should stop having sex. I remember we were having a discussion as colleagues, and somebody was relaying a story about someone who was having a conversation with some older women in the family, and they asked her, so when are you going to come in? So she was puzzled. Come in to what? You know, is there a group in the family or something that I'm supposed to join? And so she asked him to explain, and it essentially was, when are you going to stop having sex? You know, you're reaching a certain age now, so time for that done. So that's cultural, you know, once you reach a certain age, it's no longer important, but no, it's still a very significant part. So it calls for discussion, it calls for understanding on both parties' parts. You have to be willing to understand that menopause is different for everybody. Andropause is different for everybody if you believe that andropause exists, and it's not just a feature of aging. And it calls for sensitivity, right? You have to put the other person ahead of you, because let's say the male is the one that's having the problem now. So he has impotence. Impotence is the inability to achieve and maintain an erection. And for men, that is almost as bad as telling them that they have 3 days to live. So the female in that regard has to be understanding. And you would find if there's no support, it's a vicious cycle, because again, remember that there is a significant emotional component too for men. So if a man is unable to perform sexually, that plays on his mind, and therefore that makes getting an erection even harder. No pun intended. So that's my advice. It calls for conversation and cooperation.
I totally agree. I think what we have to also teach our females is that sex doesn't end at menopause. It can continue to 60, 70, even 80.
Even 80. Because let me share an experience with you. I was working in, I think this would be maybe about 3 years into my career, 3 or 4 years into my career. I got married in 2004. Yeah, so this was maybe about, I'd been married for about 2 years. And one of my patients, I can see her face now, an elderly female. She noticed my wedding rings. She said, "You're married?" I said, "Yes." She said, "Okay, congratulations." I said, "Thank you very much." And she went on to say that she was married, but her husband had died. I said, "Okay, well, you know, I'm sorry about that." And then, you know, she went on, she's like, "You know, can I tell you something?" I knew that this conversation was going to go downhill very quickly. So I said to her, "Sure." And she went on to explain to me, it wasn't crude or lewd or anything. Let me just say that. But she went on to advise me as a young wife about how, what I could do to you know, ensure that my marriage was healthy and happy in that regard, right? And I had another patient in that same department. We had put her on some medication, and we should never assume. She was 75. She was 75, and she didn't look like 75. And her boyfriend was 20 years her junior, right? 20 years her junior. So he was in his 50s. The medication that we gave her to treat her blood disorder was causing vaginal ulcers. She came back. She put it on the table and she said, I quote, "Give me something else. This is cramping my style. I have work to do. I have a young boyfriend." We had to change her medication, huh? Right. So no, it doesn't stop just because you've gone through menopause, but I agree. It's social, Mr. Burrowes, it's social.
Okay, we have one last question. I'm not sure if this is the last, but with Donna, she wants to know, are palpitations associated with menopause in some women? Palpitations.
So menopause can come with palpitations, especially after having hot flashes. But palpitations are also symptoms of other medical disorders like heart arrhythmias, abnormal rhythms of the heart. You can also get palpitations in thyroid disease. You can also get palpitations if your blood count is low. Therefore, if you're having symptoms like this, the advice is that you see your medical practitioner and make sure that you get evaluated to make sure that you can assign these symptoms to menopause and an underlying medical condition is not being overlooked or missed.
Okay, thank you so much. Since there are no more questions in the chat, I just want to thank you so much, Dr. Boyce, for your wisdom, sharing your wisdom with us today, as usual. I believe all those who are here have been encouraged and they have learned a lot. And I'm sure they'll put this wisdom to good use. So once again, we really want to thank you for our excellent presentation.
It really has been my pleasure. And if there are any questions, persons can reach out to me. You can check my Instagram page. You can reach me at 248-0434, and I would be happy to answer any questions that you might not feel comfortable, for example, maybe in this forum asking.
Okay. I'm sure that we will be here again next week, and I'm sure that any questions they can, send them off, and you'll be able to
pass them on to me. Yes, certainly, no problem at all.
Okay, all right. So we want to thank you so much once again. So we'll be here again next week, Wednesday at 7:30. We look forward to continuing these discussions in our family life enrichment series. So I want to wish you a good night all, and I pray God's blessings be on you. So God bless. Have a great night, everybody. Thank you so much.
Good night, everybody.
See you next week, 7:30.